here. It is my pleasure to introduce this webinar series from IFFS, Professor Nikolaos Polyzos. He is head of the Reproductive Medicine Department of the Exeus University in Barcelona and a visiting professor in the University of Ghent in Belgium. He has been in the past the medical director of the Center for Reproductive Medicines in Brussels and professor of OBGYN for the Free University in Brussels and also in the Aarhus University in Denmark. Nikos is a very well-known clinical researcher and has participated in several multi-center trials and has published extensively in reproductive medicine, more than 150 peer-reviewed papers, and he has covered topics like ovarian reserve, ovarian stimulation, and more recently, luteal phase support. And I'm happy to introduce you to his very interesting talk. So Nikos, please go ahead, and thank you for being here.
Thank you so much, Marcos. Thank you so much, IFFS, for this nice series of webinars. I was telling all the time that you're really innovating, and these webinars are attracting a lot of interest, and it's something that we need in the field. So congrats to the IFFS, and it's a great honor and pleasure to give this lecture. I was asked to talk about the luteal phase. I was asked to talk about the big black box of the luteal phase and tell you the different side of the story, or what we see. So we have a long time. We have time for discussion. These are my affiliations. I'm actually based in Barcelona in the University Hospital of the Zeus, and these are my conflict of interest associated with this presentation. If you see, I had research grants and honoraria from many of the companies, but this does not affect my direct opinion about how we should manage the luteal phase. And having said this, I will present my presentation outline, talking to you about the freeze mania that we are living. We're talking about freeze all and how to transfer, because we're becoming freeze maniacs. We freeze continuously and a lot. I would continue about the preparation protocols, the past and the future, and what we see. I will talk about a very serious issue and whether artificial cycle friend is dead. Is the king dead or not? Because this is something that we learned and we adopted over the years, most of us, with the vast majority of our cycles being artificial, and suddenly we have to kill the king. Should we do it or not? And finally, with the back to nature is the way forward for everyone, for some, or for whom. So starting from the scratch, let's talk about facts. What are the facts that we have? That we freeze a lot. We freeze a lot in the UK. If you see the number of frozen cycles, which are the yellow bars, they are exponentially increasing. Freeze-all is dominating our centers. We freeze a lot in the USA. This was until 2012. 2023, it's going to be like 70%. We want to see the data, but it seems that freeze-all is getting more ground. But we even freeze-all in Latin America. These are the data from Latin America published in 2021, showing that the number of frozen embryo transfer cycles exponentially increase. And if we see Europe, we have done the switch, ladies and gentlemen. These are the latest data published by ESRE 2023, showing that since 2013, the percentage of deliveries coming for frozen embryo transfer is higher compared to the percentage of deliveries coming from fresh embryo transfers. So we did it. We moved towards the freeze and the frozen embryo transfer cycles. And this is why this gained much more ground. Why did we do it? For several reasons. Number one, Paul de Bruy was always telling this, OHSS free clinic. And I love OHSS free clinic. And when you have a risk of OHSS, you have to freeze all. But also, if you want to see what happens based on the evidence of freeze-all in pregnancy rates, you will see promising results coming from China. If you can see clearly in New England Journal of Medicine in 2016, you will see that actually the pregnancy rates are significantly higher in high responders when you use segmentation and freeze-all compared to fresh embryo transfer cycles. And when you go to normal responders, there is evidence from some studies showing significantly higher live birth rates with freeze-all compared to fresh embryo transfer, or a recent study that we published with our colleagues from Denmark, and we have shown that in the general population, freeze-all and fresh perform the same. So we have evidence that it works. I would kindly ask you to mute your microphones because I hear an echo and it's difficult to talk. So having said this and seeing that why freeze mania is gaining more and more ground, we need to understand what we're doing. How are we transferring all these numerous and many frozen embryos that we create? We thaw them and we transfer them. And how do we do it? Natural cycle, modified natural cycle. We wait for the late surge, we measure the blood, we do the HCG trigger, but we follow the nature. Or we don't follow the nature. We do completely different. What we do, we give pills, we give gel, we give estradiol, we stop the patient's cycle, and what we do, we transfer them using progesterone, totally artificial. What are the pros and the cons? We have things in favor and things against. And if you tell me what is in favor of a natural cycle, the positive part of the story, I would go thumbs up for several things. No medication. If you ask me if I could achieve the same always and I had the optimal condition without medication, why to give medication? It's more natural. Nature prevails. We like nature. We like to do natural things, but still, is it for everyone? And we have endogenous progesterone production. And we have the corpus luteum, which we have heard for many years that this is important, that this can play a role for the health of pregnancy, for the health of women during their pregnancy and the obstetric outcomes. And on the other hand, what we have as a negative point, lack of planning. They come continuously for multiple controls, which is not the ideal, which is not what we want, which is not the future. It's something for the past, especially if we understand how much important this time for the patients, first of all, and the planning. We have to do continuous monitoring, and we need multiple visits. So, HRT, what we do with artificial cycle threads, the advantage is clear. Planning, planning, planning. 1 or 2 visits, excellent, easy for patients and doctors, but on the other hand, medication, not at all natural, long duration of administration, no endogenous progesterone production, and absence of corpus luteum. Do we have new ideas? New ideas are coming. And new protocols are coming, and there are 2 protocols that have been presented last year in ESHRE, telling us that we can do some planning in the natural cycles. Santos Ribeiro, Samuel, a very good friend from Portugal that works in Evidea, has done a beautiful study showing that you can use the natural proliferate phase, which says that you can actually follow the menstrual cycle and you can start your progesterone when you have a good endometrium or a good follicle without using HCG and transferring after 6 days. And on the other hand, the flexible HCG triggering that you can trigger when you have a follicle of 19, 18, 15, or less if your endometrium is good. Can this be the future? And do we have enough evidence? Evidence have been published, have been presented. This is the study presented by Samuel, by the group of Samuel in ESHRE in 2023, showing that similar pregnancy rates, similar live birth rates between natural proliferate phase, natural cycle, and artificial cycle. But wait and don't judge, because this is a study that has been presented and we don't have controlled evidence. We're talking about 1,200 cycles of natural versus 600 artificial versus only 300 natural proliferate phase, no control for confounding factors. And even if there is a corpus luteum and I start my progesterone early, my question is, how is this corpus luteum going to function? And if it's going to be efficient. On the other hand, the planning of the modified natural cycle by allowing the trigger at follicle of 13 to 15 millimeters or 17 millimeters or more than 19 appears to be much more interesting, that I can trigger my ovulation when I have a follicle of 14 millimeters to avoid a weekend. That's interesting. And I can have good results. Someone presented these results with very good pregnancy rates. Nevertheless, if we go deeper inside this presentation, we will see that there were 3,000 single embryo transfers from natural cycle frozen embryo transfer cycles from 2,700 patients. But still, the vast majority of the patients, 85%, they had big follicles, 16, 17, 18, 19, which does not allow a lot of possibility to modify your strategy to avoid the weekend. And again, I have a big question about the corpus luteum function. Is the corpus luteum function of a follicle of 13, 14 millimeters gonna be the same as 19? I don't know, so I cannot tell you if the protective or the beautiful effect of the corpus luteum function will be apparent there, first of all, and secondly, if the progesterone produced by this corpus luteum would be enough, sufficient to transform the endometrium, but also to support the luteal phase. Pregnancy outcome is the major problem when we're coming to whether the king is dead, because we have been using for many years artificial cycle, and at sometimes they come to tell us that you should change it. And there is an enormous movement against artificial cycles while we have been using it for years. And my question is why? Why should we kill the king? Why should artificial cycle that has been for many years working in our hands should not be used anymore? Is it for pregnancy outcomes? If we try to check the efficacy of artificial cycle threads compared to natural cycle and whether it's worse, we will come up to this systematic review by Gruchowski in 2020 from the Cochrane, showing to us, based on all the studies that have been published, that there is absolutely no difference between a programmed and a natural cycle in terms of pregnancy rates, suggesting to me that it's not inferior. Is it? It doesn't appear to be. A new systematic review came in 2021 by Wu in JAR, published in 2021, showing that if you compare in this meta-analysis artificial cycles compared to natural cycles, it seems that natural cycles perform better and modified natural cycles perform better than artificial cycle. However, before judging, we have to go into the data. And it's very important to realize that the systematic review is not a panacea. It's not the solution for every problem. It's like a good recipe. It's like a good food recipe. To make the best food, you have to put the right ingredients. If you put too much salt or you put a bad ingredient, the taste is going to be bad. So if we take into consideration that this systematic review included 26 RCTs and 113 cohorts, I think we have to be cautious before interpreting in such a way the results. The answer about the role of artificial, natural, or modified natural will come from big randomized trials. And the large randomized trials are coming. I know very well that the great group from Vietnam of Lan and Tuong, they are doing and they have finished this large randomized trial, more than 1,000 patients, randomizing patients to natural cycle, modified natural cycle, and artificial cycle to see if there is any difference in the live birth rates. Let's see the results. And if there is no difference, we cannot kill the king, at least in terms of pregnancy rates. And there are other studies that they are done in other parts of the world, and I would like to see the evidence. Where is the problem? Why are people telling that we don't want artificial cycle? Or why people are telling that it might not be working so much? Because sometimes we were losing the fine-tuning. Everything, it's like setting up the right engine. If you don't set it up, it's not going to perform well. And this might have been the case in HRT artificial cycles. Why? there is a very important randomized trial published in 2018 by Deviney in the United States, in which they compared 3 different groups. Vaginal progesterone only, which was a low dose, was 100 milligrams 2 times per day, versus intramuscular progesterone daily. Unfortunately, or fortunately, we don't have it in Europe, or a combination of vaginal progesterone plus intramuscular progesterone every 3 days. What was the results of this outcome was that in the vaginal only form, when there was a low dose, you had significantly higher miscarriage rates, 27% versus 14 versus 18, significantly lower clinical pregnancy rates, and significantly lower live birth rates, questioning the role of vagina. Of course, it's not questioning the role. It's how much you give and how you give it and when you give it, and if some patients are absorbing differently progesterone. The role of serum progesterone levels have been highlighted a long time ago. One of the early studies was done by Elena Labarta in 2017, in which I found that actually, when you supplement with vaginal progesterone, you can see that if you have low levels, less than 9.2 compared to more than 9.2, you have significantly lower ongoing pregnancy rates in the general population, 32 versus 52. We're talking about an almost 50% lower pregnancy rates. What does it tell me? Houston, we have a problem. I have low progesterone after vaginal administration. It's not going to work. I will have a miscarriage. The group of Peter Humaidan with Birgit Alsberg has shown this 11 days post-embryo transfer, similar results, and our group has published this, that 1 day before the embryo transfer, if you measure the progesterone in transfer of euploid embryos, genetically normally tested embryos, you will see that although the pregnancy rates are the same, you see an impressive 26% miscarriage rates of euploid embryos when your progesterone is below 10, and this is clearly affecting your live birth rates. So it's not that vaginal not works, it's that some patients might not absorb well the progesterone, and this patient will need additional progesterone administration. In what way? We will try to see it. But this appears to be the side of the story. And there, if we try to find who are the patients that absorb differently progesterone, our team has published a study back in 2020 in which we have identified the factors associated with low serum progesterone. What was the most important? A previous low progesterone in the previous cycle. So if you supplemented vaginal progesterone to your patients, and one patient has a low progesterone the day of the transfer, the day before, in one cycle, in a subsequent cycle, she will have the same low results. She has 3 times higher odds, highlighting one great thing. Be aware of absorption. Vagina, as the stomach, the mucosas, they will absorb in a different way a medication, and some patients would be affected. We see that weight can affect in a negative way, so all the patients are different. So if you administer a medication vaginally or orally that passes through your mucosa, you will have a different absorption. It cannot be the same, and it can be affected by different patients. So what we try to do, and this is the first study on individualized luteal phase support that we published in Human Reproduction in 2021, we try to do the fine-tuning of the artificial cycles with low serum progesterone levels by using the model of transferring euploid embryos. If you remember before, our study has shown that when you have low serum progesterone, you have like 40 or 50% lower chances of live birth because you have higher miscarriages. What we did, we found the patients that they had good progesterone levels and the patients that they had low progesterone levels. And in these low progesterone levels, we supplemented with subcutaneous progesterone injectable, 1 injection per day. What we found in these 600 patients that they were transferring euploid embryos is that you have similar pregnancy rates, you have similar ongoing pregnancy rates, and you have very low miscarriage rates, suggesting to us that we can rescue the luteal phase. So it's not that HRT or artificial cycles are performing worse in pregnancy rates, but if you identify these patients that might have a lower absorption, you might actually rescue the cycle and get to similar pregnancy rates as injectable. And what we have shown also from our team is that the fine-tuning has shown that even with very high progesterone levels, you see vaginal or a combination, very high progesterone levels, this does not have any negative impact on your pregnancy rates, published in Fertility and Sterility, again by our group, showing that even levels of 100 nanograms show a stable line in terms of live birth rates. You supplement, you rescue, you save. What we have been facing, and I would like to comment, a new study that came, and I saw it 10 days ago, about different progesterone formulation and serum progesterone levels. Because we have different options. We have tablets or capsule ovules, we have vaginal gels, you have pessaries, you have intramuscular, you have subcutaneous, you have all the progesterone that you cannot measure, so you don't know if you rescue or you don't rescue. So you have oral, but then a study that came and was published was interesting because if we see the pharmacokinetics, we will see that the evidence shows that if you administer vaginal administration of 400 milligrams vaginal, you will have levels that they are above 10, 11, 12 nanograms per ml. If you give vaginal gel, you have an increase in the dose that does not reach the 10 nanograms, and then it drops after a median of 12 hours. And if you give subcutaneous, especially the 25, which is in the market, which is the lower value, you can increase, a rapid increase until 40, but then it drops within a period of 6 hours. What is interesting to see is that, is there a difference between the different formulation or the doses? Do we have any evidence? Elena Labarta came with this publication. It's not in Fertility and Sterility. I'm sorry, it's RDM Online. This is the study in 2023, 2 months ago, in which they tried to evaluate in a retrospective study if there is any difference between micronized progesterone and pessaries in artificial cycle. And they found, or they supported, that there is a 10% incidence of low progesterone with the pessaries in their studies when you give pessaries every 12 hours compared to 17 versus vaginal capsules. This is a little strange, the data, because it's a retrospective study. The administration or the measurement of the progesterone has been done 6 to 2 hours, so after the administration, so it's not very clear. And secondly, these percentages are much lower to the percentages that they were presented by Elena in the past. We're talking about 30%, and it seems a little lower. But even if you go into this, the final outcome, you will surprisingly see that even if there is the difference appears to be presented higher, you see exactly the same ongoing pregnancy and miscarriage rates. Is it a matter of administration? Is it a matter of the patients? If you don't have a proper randomized trial, you cannot say what were the patients and how they absorbed the progesterone. This is really an assumption of the retrospective studies, but this cannot be reliable based on the fact that it's not based on a randomized trial. And true, if you see the literature and the pharmacokinetics with the different doses of pessaries and gel, you will see the study published in 2018 showing the pharmacokinetics, in which you see actually that once per day pessaries of 400 milligrams versus twice per day, you will see similar high levels. And I still remember the studies by Paul Devruy. This is one of the PhD of Paul, and I hope he's doing well, that he has shown that by giving every 8 hours 100 milligrams of progesterone vaginally, you can achieve the 10% nanogram. And these were talking about studies that you were measuring continuously progesterone in a very nice and meticulous ways, which we don't do it today. Frankly speaking, and to tell you the truth, I think that we managed to rescue the cycles, and we have to continue evolving and seeing new things. One of the new perspectives RCTs that we're doing to individualize the luteal phase It's something interesting in which is a randomized trial that we're running in the Xeus here with 1,020 patients, in which we randomize them to two different doses of vaginal progesterone, 203 times per day micronized progesterone versus 400 per day, 400 twice per day. As you see, this is the protocol, estradiol gel with a micronized progesterone 203 times per day versus estradiol gel compared, followed by micronized progesterone 400 milligrams 2 times per day. What we want to see, because this is a randomized trial, we want to see if indeed when we have low progesterone defined by less than 10 nanograms, we can supplement with oral micronized progesterone as another way of rescuing the luteal phase compared to patients with high levels, and this we will do it with the two groups. And the outcomes are going to be more reliable because we're talking about randomized trial. If you really see the difference, you should find a significant difference in the prevalence of serum progesterone levels, low progesterone levels between the 600 and 800 milligrams. You should find a difference in implantation rates or the biochemical and clinical pregnancy rates, and we will compare also these patients with low and high levels, but in a very big randomized prospective study and not in a retrospective study that you cannot compare for the confounding factors. The obstetric outcomes has been the major problem, however, of when we're talking about the artificial cycle threat. We can try and we can optimize, and I think we have the means to have good pregnancy rates when we do an HRT cycle compared to a natural cycle. I don't believe the evidence support the opposite, and I'm sure that the new data coming from Vietnam would validate that the king is not dead. However, when we're talking about obstetric outcomes is where the king is injured. Why? Obstetric outcomes, according to the type of frozen embryo transfer, have been seriously questioned for many years. And why is it happening? Because of this presence of the corpus luteum. Toledo has shown this beautiful slide which shows that actually when you don't have a corpus luteum, you might have impaired visualization, you might have impaired placental function, and this might be leading to hypertensive divorce disorders or pregnancy. When they are pre-existing risk factors. And this is very important to understand because we're talking about a risk of preeclampsia which exists there, but we're talking about different patients with different risk factors. So if we see the evidence, someone would say, I'm surprised. Why? Because this meta-analysis is telling me that artificial cycle is increasing by 2 times the risk of preeclampsia compared to natural cycle. Do I have a problem? 2 times higher is important. Of course it's important. If we see the literature, we will see that the hypertension disorders of pregnancy is increased by 1.9 times. If we see the postpartum hemorrhage, 2.5 times, and the C-section risk, 1.6 times. So someone would say that, why should I put my patients at risk? But the answer that comes is, first of all, a risk of 2 times higher is important depending on which percentage you apply it. If I apply a 2%, a 2 times fold increase to a percentage of 20%, this is going to be 40%. I don't want it. But if I apply to 1%, that becomes 2%, is it such relevant? And if I can identify the patients that they don't have risk, can I minimize the risk to 0%? That came with a new systematic review showing this higher risk associated with artificial cycle. And came with this graph, which if we see it, we say we shouldn't do artificial cycle because it's less safe to the mother and the child. However, we have to be realistic and we have to see numbers. And we have to quantify the actual risk. We have 100 women. If we're talking about the risk, how much is the risk? How much is the risk of preterm birth, of large gestation age, or hypertension? It's 1 out of 100. Higher risk, not that you will have it. If you're talking about hypertensive disorders or postpartum hemorrhage, it's 3 out of 100. And if we're talking about preeclampsia, it's 4 out of 100. So, should we go back to the nature for all? Back to the nature. You listen to it and you're happy. Nature is always nice. But is it for all? Is it for some? Should we demonize HRT? Because we're living in the era that everyone is demonizing HRT. It's the bad boy or the bad girl of reproductive medicine. Is this the case? I have seen this article and I liked it. Why? Because it's a nice arbor, or it's a nice tree of decision. It says that you have frozen embryos available to transfer, but you have to assess the risk of hypertension disorders of pregnancy. And my question to you is, how many of you is assessing this risk in your clinics? Possibly no one. So we group all together. So you understand that natural cycle or modified natural cycle should be priority in patients at risk. But should we really be so scared and so afraid for a programmed cycle when they are not risk factors? 32 years old, young girl, for the second baby, after an artificial cycle which was normal, she wants to go for a second artificial cycle. No risk of preeclampsia, young age, second baby, not nulliparous. What is her risk? She's living 100 or 1,000 kilometers away and she doesn't want to do the testing all the time. Have we ever thought of this before making one decision for all? And I would like to ask you some questions. Question number one, can we go back to nature for all? Do all the patients have a regular cycle, yes or not? Second question, is the risk the same for all? 42 years old, 32 years old. Is artificial cycle threat the major problem for preeclampsia that we're listening? Or there are other factors that we close beautifully our eyes and we don't look at this? Can we still prevent preeclampsia in artificial cycles? We're in 2023, we're not in 1973. And do we need to wait for more evidence to go back to the nature for all? Let's go and see one by one. Can we go back to nature for all, ladies and gentlemen? This is the HFEA fertility treatment data. You see that you have around 5,000 cycles with patient eggs and donor sperm, and you have another 3 and another 1,500, exactly the same, going with donor eggs. Who are the patients who are using donor eggs? 10% between 40 and 42, 20% between 43 and 44, 60% at 45 and 50. All these old patients that they are coming to us, it's like 90% sure that they will get pregnant with donor eggs and they will not have menstrual cycles. At 46, I would like to have a regular cycle. Unfortunately, I don't have it. I don't know how this corpus luteum will work. Is the risk the same for all? How many times haven't we sat down to identify or quantify the risk? These are the different countries. IFFS is in a world organization. What you see here is that the risk of hypertension disorders is 300, the prevalence is 334 in Africa, and we know the race impact on this, 16% in Western Pacific, it's 75% in Europe, it's 81% in North America, and it's 45% in South America. Have you ever took into account where our patients is coming from? Are we worried? Should we worry the same, more? Are there specific regions where you have to go more to the natural cycle if you can it, and others that it's not that big deal? Because if you see here, and if we're talking about Africa, where you see, and I see a lot of attendance there, of course, if we're talking about Somalia, Nigeria, Chad, you have a very high incidence, a very high prevalence. And this is where, if you can avoid going for the artificial cycle, this will make a benefit. But if we're talking about Switzerland, Germany, Norway, Monaco, that we have a very, very low incidence, would this be so, the impact so great? And should we fear so much? On the other hand, how many of you are checking about non-modifiable or modifiable, because these are the modifiable risk factors? Antiphospholipid antibodies, previous preeclampsia, family history, or maternal age. We see this is not modifiable. Are we checking for antiphospholipid antibodies to all the patients? It gives you 9% higher risk for preeclampsia, 4.5 times more than an artificial cycle. Are you checking for a previous preeclampsia, or are you selecting your patients? Because there Of course, you should avoid an artificial cycle because you have 7 times higher risk. What about maternal age risk? Or what about nulliparity? Instead of checking the non-modifiable risk factors and identifying risk patients that they should go to a natural cycle, we put it for all, which is not the future. This is the past. We're talking about an individualized luteal phase support, and we're talking about a totally non-individualized selection of the protocol to transfer. And if we're talking about the adjusted risk, you see the same. But if we're talking about modifiable risk factors, what are we doing today? Let's see the data. Twin pregnancy, adjusted, increases by 4 times your risk of preeclampsia. How many embryos or how many clinics or how many of you are transferring 2 embryos? Many? Is it 0? So if it's not 0, you're harming more your patients by transferring 2 embryos than by doing an artificial cycle. Secondly, high BMI at booking or before pregnancy. A BMI of more than 29 is 519 the risk of preeclampsia. I have seen studies coming from the States in PCOS women with a BMI of 35, 39. Shouldn't this be changed? So are we actually demonizing the artificial cycle by not looking into account the actual risk of the patients? Look about the double embryo transfer. These are the data, and these are the data of Europe. 50% in Europe continue to do double embryo transfer. We will change to the natural cycle, but we will not change to the double embryo transfer to single embryo transfer. This is paradox. This is not reality. This is a misconception of what we're saying. So instead of demonizing one artificial cycle, let's see what we're doing. What is the BMI? This is the percentage of patients published in the USA that they have treatment. 56% or 59%, they have less than 25, 23 are overweight, 18 are obese. And it's the same in Canada. But of course, if we change and we go to the natural cycle, we will prevent preeclampsia. While the high BMI has a more higher impact on the risk of preeclampsia. Can we still prevent preeclampsia? Have we ever seen what is happening in our field of obstetrics? We're not doing the same. Nikolaos published this with their group and shows that the aspirin 150 milligrams can reduce by 60% of the risk of preeclampsia. You see it very clearly. The early preeclampsia really drops compared to placebo and aspirin. And we're talking about a risk of 0.38, more than 60% drop. And this is that in these cases, if we apply aspirin, or from the beginning, or when we see that we do the triage, can we really reduce the risk? These are questions that they need to be answered before killing the king. And do we need to wait for more evidence to go back to the Nature for All? I know that there is a big trial done in the United States, the NATPRO trial, and we hope that we can see if this trial will show us if natural cycle can really eliminate preeclampsia or it's better in terms of obstetric outcomes. So, ladies and gentlemen, we have artificial cycle threat. We're telling that it's not working well because we have lower pregnancy rates. The answer is no. Pregnancy rates in artificial cycle threat are the same with natural cycle based on the current evidence. And we wait for the nice study coming from the group of Vietnam showing to us if natural cycle, modified natural cycle, and artificial cycle threat give you the same results. But what we're doing, we're demonizing, unfortunately, the artificial cycles. And we start shooting the artificial cycle with pencils, with bullets, with knives, because it's the bad thing that ever happened. What is the legal liability based on the polemic status against artificial cycle? Should we permit it? We are clinicians, and we will continue doing artificial cycles for many of our patients. But we still throw bombs and throw knives to the artificial cycles. This is not correct. Should we act responsibly? And should we think before deciding how to penalize and how to attack one treatment strategy that we have been doing for years? Why are we stimulating and not using natural cycle? Natural cycle has been shown that reduces by 30% the preterm birth. how many natural cycles are done per year? Few compared to stimulated cycles. Why wouldn't ICSI for all our, or the ICSI rate is really exponentially increased for all the patients compared to non-male factor infertility? And this is not the proper way, but still we continue to do it knowing that the ICSI babies might have more problems. So my final message is that stop demonizing artificial threat. It gives you good results in pregnancy rates. It has an increased risk of preeclampsia because of the lack of corpus luteum, but an increased risk of preeclampsia is coming by many other strategies that we're doing. And instead of shooting the king and killing the king, we should try to see where the king can rule. The kingdom is not the same. It's going to be smaller, but the kingdom will stay forever because we want to plan, patients want to plan, and this is an efficient way. Having said this, I would like to close the session and invite you to join our Congress in Barcelona that we will do next April, in which we will have a specific session also for the luteal phase and a lot of controversies and debates. Thank you so much for your attention.
Thank you, Professor Polyzos. That was an amazing presentation, and thank you very much. You're always challenging us with these questions that are obviously what we do in our practice every day. We have a lot of people joined in. We have around 70 to 80 from all over the world. I can see some colleagues and friends that we would be delighted to have your questions in the chat box. Maybe to start, I would like to ask you about different progesterone presentations. You showed results of some studies comparing different progesterone vaginal presentations. Is there any place, or what happened with progesterone gel? Because everybody seemed to use progesterone gel in the 90s and a few years ago too, but we've stopped using it. I don't see very many studies on progesterone gel, so I was wondering if still if people use it, if they still use it once a day or they switch to twice a day. What do you think?
Super, great question, Marcos. So actually, what I see is in Asia, they're using gel still. They're continuing using. I was in China, I see that they're using gel. The studies has been shown that in artificial cycles, one gel is not enough. There is a study by Birgit Alsberg. I have participated in the study that we have shown that when you use one gel per day, you have significantly lower pregnancy rates compared to two gels. And this makes sense because if you see all the pharmacokinetic studies, it goes to a level of 8, but this does not increase, and then you have a rapid drop. So based on this and based on the fact that in artificial cycles, you don't have the endogenous production, this is a great handicap. And also it's a matter of price. Going for two gels, the price is higher, so this is the problem, and then they use combinations. But I think at least in Europe it's dropping. What I have seen, Asia it's continuing. They have a very good acceptance from the patients, and it depends also on the acceptance on each patient, how they feel comfortable with the vaginal administration.
Okay, thank you. Somebody in the chat, Sally Arkan, is asking if you would consider comparing pessaries with the same dose of capsules in a prospective study, because I think that she's mentioning Labarthe study that didn't compare the exact same dose between the micronized and the pessaries.
They tried to do a different dose because they were giving two capsules of vaginal 2 times per day versus 400 the pessaries. Without a prospective randomized trial, you cannot rely on this. So this is a study that actually showing that there is a small difference in the concentration of progesterone in the women with the cutoff that it's arbitrarily taken in the center of Elena. We have a different cutoff. We have 10 milligrams, so 10 nanograms. So it's not 8.8. It's 8.8 because in their group they found it. And they found a small difference of 12 to 17. but the pregnancy rates were exactly the same, were identical the same. So to understand what is the clinical meaningfulness that you have less progesterone levels without, not in a prospective study, not designing when to measure the progesterone levels. It's not a study where it has been designed to measure only progesterone. When you power for an outcome and you say, my outcome is progesterone levels, I have to make it very standardized, because even 1 hour or 2 hours of different administration, it can make you a difference, especially if you consider one cutoff. My cutoff was 8.8. So if it's 8.9, I will have lower results. We know very well the fluctuation of progesterone during the day. So if the 17% that they say that it's lower the progesterone with micronized, it was actually, instead of 8.8, 8.7, this has no clinical relevance. So this is what we need to take into account. A study done by this, it's interesting to see it, but we want a randomized trial. And that's why we're doing the randomized trial to find this and a proper measurement.
Yes, and before I go back to some questions, you mentioned the cutoff level and also the timing of blood sampling. Can you give us some practical tips about that? If a patient puts a vaginal progesterone in the morning, at what time should she get her blood sample?
The blood samples in the study by Elena was 6 ± 2. If you see the pharmacokinetics, yes, it takes some time to build up, but the longer you are from the last administration, especially if you use the lower dose, you will have a lower level. This is clear. This is clear. So actually what we say is that, yes, you can measure 6 hours after the initial administration, but if you don't have it very well set and organized, and this is in a retrospective manner, you cannot rely so much on the evidence. This is the major problem from the previous studies that we have done also with the measurements of the progesterone just the day before the day of administration, which that's why you cannot say for sure that this is the major difference. But still, if you have accumulating evidence showing in the same direction, it simply tells you that the story is true. The cutoff level might not be true, but still we take the 10 nanograms because I still remember from the old times, Marcos, when I was talking with Paul Devry, that he was always telling 10, Nikos, this is the cutoff, no below 10. And this is what we consider as luteal phase deficiency in the natural cycles, isn't it? So this is what we wanted.
Good. Radwan Farah is asking, when we give cyclogest for frozen ET cycles, should we measure serum progesterone before the transfer? What progesterone what progesterone lab assay when we give cyclogest?
Unfortunately, there is no study that you have done with cyclogest to determine the progesterone levels. All the studies have been done with micronized progesterone. So this is a major problem. You say that they have a lower progesterone levels, but there was not a study has been done. All the studies that have been done determining the cutoff levels have been done with micronized progesterone. So the cutoff levels, you have them there. Of course, you can measure it and you can extrapolate, but still each patient is different. Each formulation is different. Having to account that we have a large body of evidence based on the micronized progesterone showing the cutoff levels, and then we can supplement and few evidence. Let's wait for more evidence and then let's decide it. But I would measure it because in principle, it has shown that low progesterone levels are related to higher miscarriage rates.
Another interesting thing about the cutoff levels is what is your coefficient of variation in your kids' progesterone? Because if you have between 7 and 8 or almost 10% in some cases, then a 10 could be a 9 or an 11.
Exactly. So you can never find this is very important. This is very important. Also, you can say factors that they're affecting, because we know one is the BMI it's affecting. Another important factor is that there is a small variation during the day, because we have measured it, we in the group of Petros and Touli, and we have shown that they can be like 1 to 2 nanogram variation. So selecting a cutoff per definition can penalize or can give a premium to one of the two groups, especially if it's a retrospective study, because of this variation.
Okay. Ricardo Santos is asking, what is your opinion on natural cycles in which you start progesterone whenever endometrium is okay? I think he's mentioning about an NPP protocol.
The NPP.
Yeah.
The NPP protocol is an interesting protocol. So when Samuel Santos Ribeiro has started and presented this data, I found it very interesting. What is my question? We don't have prospective studies that we evaluated or comparison studies. It seems to be good. It seems to plan, to be able to plan, and it seems to give you good pregnancy rates. My great question is, can I have a luteal function that works best or not? We're starting progesterone earlier. They will ovulate, and they appear that they will ovulate, but I don't know how good is going to be this corpus luteum. So I would like a prospective comparison to see what is the role compared to the gold standard. If the gold standard would be the natural cycle or an artificial cycle, I would like to see a randomized trial comparing natural proliferative phase cycle versus artificial cycle to see if it's equivalent or better. And you don't have evidence about the preeclampsia because we say that this is going to prevent preeclampsia. Will it prevent it? Yes or not. If the corpus luteum is working well and if there's a relaxant. But if it's not preventing, again, we're demonizing the artificial cycle with something that we don't know if it's working. Let it come and let it work and let it try it, but still, don't demonize this.
Right. What would be, Dr. Ben Sassi is asking, what is a maximum dosage of progesterone acceptable? And if there is a toxic cutoff level the day before FET, I mean, I think he is mentioning some cutoff level that you really don't transfer or you don't thaw.
Well, from my experience, we're not using intramuscular, so we don't have these cutoff levels. And some of the kids, they don't measure. They say to you more than 60. So you have to do extra testing to find this. But based on the study that we have done, we published in Fertility and Sterility, we have seen that up to 100 nanograms per ml, it was not a negative effect. That's what we have seen. In the United States, I will take the great example. They are using intramuscular and they have excellent pregnancy rates. And the intramuscular is really shooting very high the pregnancy, the progesterone levels. So I wouldn't expect to find the toxic, at least based on the current formulation, to find a negative outcome. But there are some patients that they really do not absorb. I remember one of my patients, Sepide, what's your name, that she was really miscarriaging all the time, and I had to go with 2 intramusculars that I tried to find somewhere, and she maintained the pregnancy. We're talking about 7 miscarriages all the time with very low progesterone. I don't know why this was happening. So patients are different, and we have the extremes. But I don't believe that high progesterone would really have a negative impact, at least in our hands, what we have.
Thank you. Yang Su is asking, before having more solid evidence, should we routinely put patients on aspirin for FET cycles?
I like this, and I do it, especially this is what changed for me. The studies on the preeclampsia risk with artificial cycles was really something that when I saw it hit me also. Oh, I don't want to put my patients at risk. Some of the patients that they will really be at risk of preeclampsia would be menopausal, that they are going for oocyte donation, because oocyte donation also increases the risk of preeclampsia. So what I do, the patient at risk, I put them because we don't have any evidence against the aspirin that we will risk the patients. And of course, they have to do the triage to see what's happening. But I'm doing it just to be on the safe side. This is defensive medicine. This is not evidence-based medicine, but I feel at least comfortable.
Thank you. Do you measure progesterone before fresh embryo transfer? Dr. Ben Sassi asks that.
That's a very interesting question because we don't measure it. Of course, there are studies by Hack and Yarali. A very recent study by the group of Hack and Yarali has measured progesterone levels on day 3 after oocyte retrieval and on day 5. And what has shown that if your progesterone level is dropping between 3 and 5, then you have a lower implantation rates, lower pregnancy rates, but not miscarriage rates. Because progesterone there can play a transformation role, a transformation of the endometrium. Normally, you don't expect to have an outcome because you have, it's like a Tesla, you have a double production. You have the endogenous production and you have the exogenous production. So your progesterone will never be below 10. Still, you don't know how some patients will perform, and you might need to add extra progesterone, but I don't have a routine measurement for them. it's not easy and it's not practical, and I would like to wait for more evidence before I do it.
Thank you. There's a question also regarding cyclogest pessaries, adding a rectal pessary to the vaginal pessary, but they're talking about cyclogest pessaries. I don't know. You mentioned you didn't have cyclogest.
We don't have many data. The evidence that has been done, additional of rectal administration, has been done additional to vaginal macronized. So what Peter Homaiden has done with his studies published in Reproductive Biomedicine Online, that he was supplementing with macronized vaginal progesterone, and then you can supplement with rectal as a rescue form, which appeared in a retrospective way to work. I think that we have to evaluate the evidence, and for me, I'm telling you again that you need to see where the bulk volume of evidence is coming. And that's what I trust. I trust the evidence, and I try to follow up what has been published.
Great. My question would be, when you use the subcutaneous progesterone rescue, I saw the papers where you follow up that for 10 or 12 weeks. You still do that for the whole first trimester, or you?
Because of the fear. No, not the first trimester. So we stop at 10 weeks of gestation. 10 weeks of gestation, I think it's enough, and we know that it's working. Probably you could stop earlier. But the lack of knowledge is what makes us do things that we exaggerate because we believe the best of the patient. I think this is the same that we're doing in all the fields. So it's true that when it's slow, we need to supplement. It's true that we need to supplement until the placenta takes over. We know very well that the placenta starts taking over at 8 weeks, but it's not fully functional. And we know that at 10 weeks, the placenta, it's fully producing all the hormones that we need. So my suggestion would be to go to 10 weeks because we don't have any evidence. If I had evidence that stopping it at 8 weeks or at 6 weeks, I could have a good results, I would do it. But there is the only production that you have in artificial cycles. So
yeah.
I continue.
What about when you use a natural cycle? Do you, even if it's modified or natural, do you supplement with progesterone? Because there's some confusing evidence in the literature. Some meta-analysis say we should use it, and people from Belgium published that we should not use progesterone when we do a natural cycle. What's your opinion?
There is a recent study also coming, last 2 year study coming from Sweden showing that you can supplement. And I know very well that Anja Pinborg is doing a very big randomized trial, supplementation or not. I think this is a very interesting study that will solve the question. I'm supplementing. Why am I supplementing? Because not all the patients have the same luteal phase. So if you're using a natural cycle, you need really to define that you need to rely on the endogenous corpus luteum production. And as the stimulation is different, the corpus luteum functions differently. We don't know what a corpus luteum of 41 years old would be compared to at 30 years old. We don't know how is the progesterone going to act from a high BMI for a low BMI. So again, being safe than sorry, I prefer to continue and start and apply progesterone supplementation in the natural cycles.
And when do you start it? At the embryo transfer or before that?
Well, this is very interesting. We started before that because a study that we have published in human reproduction, I think 5 years ago, we have seen that when you are using a natural cycle and you have low progesterone levels, we have lower pregnancy rates, but not higher miscarriage rates. It was a lower implantation. So it's a matter of transformation of the endometrium. If your corpus luteum is not functioning well, the major problem that will affect the implantation as well, because you will not have a good transformation of the endometrium. So starting and planning a cycle with progesterone will secure that at least you have a nice window of implantation. And then you continue it. I think 6 weeks is enough. You don't need to go to 8 weeks. 6 to 8 weeks maximum is enough.
Okay, what about a natural modified with agonist triggering instead of HCG? What do you think about that?
Well, I wouldn't go to the agonist trigger. Why should I? If I have the option to stimulate more my corpus luteum and produce more progesterone during the luteal phase, why not HG? So I would do with HG. I don't see that
It's a
advantage.
longer acting.
Absolutely, absolutely. It's longer acting, and actually you stimulate your corpus luteum and produces more progesterone. So I would go with HG.
Well, thank you. I'm looking at the chat box, but I don't see any new questions.
There is one about the trilaminarity of the endometrium concerning the type of progesterone.
I skipped that one. Sorry. Yes, exactly. What about the importance of the pattern of the endometrium, the trilaminarity, before starting progesterone?
It gives you a nice feeling when you see it. That's true. Yeah. So when I see it, I say, what a beautiful endometrium. But I have seen endometria that they don't have any trilaminarity and they go very, very well. There was a lot of questions at the specific time regarding the compaction of the endometrium. So I think that Bob Casper has done some evidence published in Fertility Sterility showing that the bigger the compaction of the endometrium, the greater the pregnancy rate, because this shows the good transformation. But this was not replicated by other studies. So I will transfer if I have a good endometrium. If it's not trilaminar, I don't care. Especially if I do artificial cycles, many times you don't see this. If it's a natural cycle, it's good to see it. I don't know evidence that this will show you a higher impact or a higher pregnancy rates, at least as far as I know. Thickness is important. I like a good endometrium, and I try to go into this independent of the trilaminarity or not.
Yeah, I guess we all see patients that never have a trilaminar endometrium, but still with a good thickness, they get pregnant. Yeah. Somebody asking what is the acceptable thickness
of the endometrium? If you ask Barry Sata, he will tell you nothing. So because he have published evidence already that the thickness does not count. If we take all the evidence published on the most of the studies, it seems that endometrium 7, again arbitrarily, more or less 7, seems to be good. But I can tell you in some patients, you will not be able to reach them. And I have patients with 6 endometrium that they will have a beautiful pregnancy. You see a nice endometrium that you cannot reach it, even trying 2, 3, 4 different types of administration. Don't be obsessed. Transfer with a 6. I have transferred with 4.5 and I had a pregnancy in Brussels. I still remember it's a nurse there that she got and we never believed it.
Yeah. Christos Phyllis is asking, well, comparing progesterone levels in fresh and frozen cycles are obviously quite different. So can we compare those different progesterone levels?
Well, it depends on what you consider the progesterone. So normally, if you see the studies published by the group of Peter Humaydan, they have shown that in the first cycle, you have an increased pregnancy rates until 111, and when the progesterone goes higher, the pregnancy rates drop. There are 2 studies only, so I don't know, and I cannot rely on this. I would like more evidence. If you ask me about comparison, it depends on what you want your progesterone. If you want to support your luteal phase and the progesterone is important for maintaining the pregnancies and reduces the miscarriage rates, I would stick to the Paul de Vries 10 nanograms per ml that he was always telling me, and I would say that's good. But still, it's an assumption and not an evidence-based approach. But I wouldn't so much worry. In the stimulated cycles, you have endogenous production. It will never be zero. So I don't know. We need more evidence about this.
Yeah. Paulo Cespedes is proposing if an algorithm, maybe with an application, could pinpoint the risk factors of patients that need the progesterone supplementation. Probably if you factor in all those variables, the BMI, the smoking. I read the French paper identifying smoking like favoring and non-Caucasian origin of the patients. So maybe we can factor in all those factors too.
That's a very interesting approach, and Pablo, that's very interesting. I like it. What I would like to tell you is that what is the problem with preeclampsia? It's a rare event. You have 1 cases out of thousands, so you have to fight to find 13 cases. So the problem is not that you cannot find it. AI can work if you combine a lot of data sets. But the major problem is that first, you don't have data sets that they give you to until delivery or until the pregnancy. We are good. We are happy because we have a hospital which is upscaling in reproductive medicine and we can follow them to the end. But not all the settings have this. Many patients would be with lost at follow-up. Secondly, preeclampsia with preeclampsia is completely different. You have an early onset preeclampsia, which can be disastrous. You can have a preeclampsia 1 week before delivery, which cannot be a problem. So, and depends on the degree. So sometimes we group together. But what I want to transmit is that, yes, maybe if we combine a lot of data sets, we will get this information. And I like this idea. I think, Pablo, it's an interesting idea if we can work on this and we can find something. Still, until we have this evidence and until we identify, do not demonize. This is going to be against us. There are going to be lawsuits that we will not be able to save. And this is not at all correct. It's a malpractice and it's not correct medicine. While we know that many of the patients need an HRT cycle or ask for an HRT cycle.
Thank you. I guess we're almost done with the questions. I'd like to thank everybody for being here. Nikos, that was great. I think you reviewed all the current state of the art in progesterone and luteal phase and frozen embryo transfer cycles. I think there will be more information coming up with those randomized controlled trials, and we look forward to that, more data on this interesting topic.
Thank you so much, Marcos. Thank you, IFFS, for the beautiful webinar, and thank you all for attending. It was a great honor to be here.
Thank you very much, and you have all a nice holiday season and the end of the year. So thank you very much for being, and we have to thank also Byzance for supporting these webinars, and we still have a few more to go during January and February. Thank you very much.
Thank you. Bye-bye, everyone.
Bye-bye.